You're watching Are They Safe in There? Clinical Supervision and the Use of Random Case Analysis. Produced by GP Supervisors Australia and presented by Dr. Gerard Ingham. We would like to begin by acknowledging the traditional custodians of the land on which this recording was produced and pay our respects to their elders past, present, future and their families.
Welcome all. If there's anything that a supervisor new to the profession needs to do at the beginning, at the end, and throughout their supervision experience, it's to establish the safety of a registrar. But this is very much focused on that and talking specifically about random case analysis as a tool. My name's Simon Morgan. I think many of you know me as a medical educator GP here in Newcastle. But it's certainly a great pleasure to introduce a very, very long-standing friend and colleague, Gerard Ingham, on a topic that's dear to both our hearts and something we really wish to inspire a passion in you about. So Gerard, take it away, and it's wonderful to have you on board.
Thank you, Simon. Nice to be working with you again. I think this is a photo probably taken about 2014. I'm thinking when we first started running roadshows on random case analysis, and we bought these T-shirts together, and you can see I'm obviously from Victoria because I'm paler, from Dalesford, Victoria, which is about 100 kilometres northwest of Melbourne, and I'm a GP supervisor and a medical educator, and in more recent years academic. So Simon and I have worked together over many years, and probably it really started as working together as academics and medical educators when we're trying to remember, we were coming back from a workshop which we were involved in presenting, or perhaps Simon was presenting and I was tagging along in Gippsland, and we started to talk about random case analysis, which was something that he'd had experience and knowledge of in the UK. And we started to come up with the idea of, gee, this would be a really useful tool and we should publish on how you could use it in an Australian context, because at that stage it really wasn't being used. It wasn't part of the lexicon of Australian GP training. And we published this paper together. And since then, the use of random case analysis has taken off in Australian GP training. And I've been on a bit of a journey and a bit of a research journey as well relating to that. So we've done quite a bit of published work on the use of random case analysis. And we've also looked at other areas as well. So we added it to the ECTV. We did some research about whether that makes a difference to supervisors' confidence and ability to assess their registrars. And we've also been very heavily involved in GP supervisor education through to this day. We're currently working on a project, the two of us, on looking at a national curriculum for GP supervisors. So, but I also don't only work with Simon in that circumstance. I play with Simon as well, which is a play in the band. And this is a bit unusual because I get to, you see me there normally playing bass guitar in the background of our all GP band, the Euthymics or the Cheeky Docs, and I'm normally on the bass, whereas Simon's the lead singer, guitarist out the front, and so I'm normally doing the solid groundwork, and Simon's taking all the credit out the front. So this is a bit different. I get to actually speak. So there we are. So it's good to start this workshop. It was lovely to get a question to come before. As this one came to us, I found myself intervening over an urgent result that was time critical, sitting in my registrar's inbox unchecked. I then found out that it took the patient 7 days to book that DVT scan, as the registrar felt that it would come back normal. And you can sense the exasperation in the next sentence. How do you teach a registrar common sense and teach proactivity? And that's, Simon and I have got to fix this problem. So of course, like any educator and like yourselves as supervisors, you always, whenever you're asked a question, you always answer a question with a question. So even better, ask a number of questions. So this would be my question about this registrar. What does she know about the management of an abnormal result? Presumably in this case, it must be a D-dimer or something that suggests a DVT needs to be excluded. So what's her knowledge that makes her think that it's all right to wait a week? How would you find that out? What her clinical reasoning and understanding is? And the final question is she safe? Really, is she safe to be going as a registrar, continuing to work, and you're only finding out these things by chance when you stumble across it in the inbox? So, whenever I've worked with Simon, I've always known that Simon likes cartoons. This is one that I've shared with him in the past, and it's got Superman's Apprentice. And I think it's a reminder that we work in an apprenticeship model as with supervisors and our registrars. Also, I'd probably say, look at this and you can see, well, what's the features of supervision? This is direct supervision. You're actually observing the work that's being done. You're checking on safety. You can see whether the super boy is going to burn the cape, we're going to make any mistakes. You can also see that there's a relationship between the supervisor and the registrar, in this case, or the supervisor and the apprentice. And you would have to look at this and think, well, I don't know if that relationship is going that well. And that's not very good for the ongoing development of a new Superman.
So there's no suggestion, Jared, that supervisors need to wear their underpants on the outside of their trousers in presenting that.
No, I know we like to demonstrate good behaviour, and it's good to point out being an anti-role model, and that is definitely not being a role model there. So we move on to remind us what we're required to do as a GP supervisor. And it's often said that our main two jobs are to be clinical supervision and educational supervision, which can be simplified by thinking clinical supervision, which is ensuring that the registrar's patients are safe. And then educational supervision, which is ensuring that the registrar is learning. It's a bit of an artificial division because most of the time we're doing both. So when we're going to talk about random case analysis, we're going to look at it mostly through a lens of ensuring safety, but it's clearly an educational tool at the same time. So it's very rare that we're only doing one or the other. Obviously, when we're going into our consultation room and reviewing a registrar's work in a consultation, that's mostly about clinical supervision, whereas when we're in a teaching session, it's mostly about educational supervision. But most of the time, our activities have a combination. And more recently, we've realised that there's a further circle that needs to be added, which is, are we looking after our registrar, and is the registrar okay? So that's seen as our role. So let's look further at clinical supervision. And in this cartoon, the supervisor in this case says, it's not that complicated, just give the man a haircut. It ain't brain surgery, as he takes off the skull. So clinical supervision, supervisors must have clinical oversight of the management of the registrar's patients, including quality of care and patient safety. And here's the big kicker, which is you are responsible for the safety of a registrar's patients. Usually if we sell that at the start, supervisors say, well, no thanks, GP supervision is not for me. I didn't really realise I was signing up to that, and usually run away and talk to the medical indemnity provider. But look, it is a responsibility we need to take seriously, and it's about how you set about doing it. And the focus today will be making sure that you do have systems and examining your systems to look at the safety of your registrar's patients. So how does a registrar start in your practice? Does the registrar start with you observing all consultations till I'm sure they're safe? Or I observe a few consultations at the start and then ask for me to call for help when needed? Or I don't routinely review all of their consultations at the start? Or it's not relevant to me, I don't have any. Most people review a few consultations at the start, then as needed after that. And that probably would be my expectation, that that's probably the most common way. Then I am aware, and I've certainly had experience, of a few people who do review all consultations at the start until I'm sure that they're safe. And there's also obviously some who don't routinely observe any of the consultations prior to just letting them start from the start. So what's the significance of this is probably to share with you some recent research and publications about this. So the first one I want to share, the one on the left, is a publication last year by Susan Wern, Parker McGinn and Neil Spike, who are three very well recognised academics, looking at the fact that, well, what's happening now when doctors are coming out of hospital is that they're less prepared than they ever were to be GPs. Most of their hospital training is not a broad experience. They don't see general practice type problems. They see less and less of them in hospitals. They're often at the bottom of a very big rung. They've often not had to make many decisions and been responsible for them. There's not so many broad general medicine or general surgery terms. They're doing neurosurgery or nephrology or something, and so they're not getting that breadth of experience that they were getting before. That's the first thing to point out. So they're less prepared for when they come to general practice. And then this other paper or report, there was a review in 2018 of comparing Australian general practice training to international models of GP training. And what's different when you look at Australian general practice training is we're actually relatively unique in starting our registrars off without a period of mandatory being supernumerary and being under supervision. So many international doctors coming to Australia are quite horrified at the fact that we start doctors off without there being a mandated period of being supernumerary and that all their consultations are reviewed. That's actually the standard elsewhere. When I've seen these two papers started to make me think about, well, how do we start and are we making them safe? And so I set about doing some research which involved I interviewed the directors of training of all regional training organisations to find out what is our safety system in Australian general practice training. And when you look closely at it, you find it's quite stunning that we have this system which is almost devolving responsibility down. So if you look at it, I haven't got them in here, I've got RTO and supervisor, but above that, you've actually got the college. The college sets the standard. The college, well, I'm talking about RACGP, and ACRAM's standard is much the same, which is registrars should only see patients that they're safe to see. That's what the standard says. So we make this standard, so okay, therefore we can, and we tell the RTO, the colleges say, tell the RTO, make sure you implement that, but they don't check. So then the RTO says to the supervisors, well, you make sure registrars are only seeing the patients that they're safe to see and competent to see, but they don't check. And the supervisor says to the registrar, well, call me if you think you need some help. And so you can see this is moving down. So the least powerful in the system, the registrar, is actually left with the responsibility of ensuring safety. And when you look at that, no one would design that system. It inherently looks unsafe because the standard which is being set, that they should only see people they're competent to see, is having to be enforced effectively by the registrar. And I mentioned, Simon, and I've done some work before. This harked back to earlier work which we'd done. We actually trained supervisors up in doing random case analysis. And we then went back and asked them some questions, survey 6 weeks later. And we weren't looking to find this. And one of the questions buried in our survey was, oh, did you find any safety concerns when you looked at the notes? And did you need to contact a patient about that safety concern? The research wasn't looking at that. And in this survey, we found 30% of supervisors, when they, for the first time for many of them, opened up their registrar's notes and did an audit of their registrar's notes, found a safety concern. And 16% of them needed to contact the patient. So it automatically, again, raises that concern. Wow, are we really got a safe program here? Because there's safety concerns being found by nearly a third of supervisors looking at the notes. So what's the reason why we wear this T-shirt, Simon and I, is that your registrar is never going to call you about problems they don't know. So they're so-called unknown unknowns, that famous Donald Rumsfeld quote, you know, the known unknowns and such like. So a registrar will never call you for supervision when they don't know that they need to be calling you. And that's probably the basis for the reason why they're finding all these errors. Of course, there will be the registrars who fail to call when they should and knowingly do that, so-called known unknowns, but most of the time it's unconscious incompetence. So if we're not going to, here's the model which we mostly do, which is we mostly say, look, we're going to watch a couple of consults, or you can just start automatically and call me when you need to. That's the way we've always done it. Just like here, we've always dug coal out of the ground or drilled for oil. What happens if all of a sudden we have to do something alternative? And just like in this cartoon, the alternative is relatively staring us in the face, but we don't want to acknowledge it. And the alternative is doing one of these four things on the left side of this. So these are all different levels of review before allowing a registrar to practice independently. And they're obviously decreasingly resource intensive. Obviously, if you had to sit in for weeks and weeks and weeks until you were happy that they were safe, that would be very resource intensive. Then there's end of consult attendance, a so-called wave consultation, where the registrar sees the patient and then you come in and physically attend and review the work before the patient leaves the building. Then there's this end of consultation phone review, which would be the registrar would see the patient and would call you and say, I've got so-and-so with so-and-so and I'm planning to do that. Is that all right? And then obviously the final one is end of session review of notes, where you just sit down and go through at the end of the day. So the first three considered what's called level 1 supervision under the Medical Board of Australia or APRA guidelines, and end of session review of notes is sometimes called level 2 supervision. I've put across the page because you can see not only is decreasing, each one has a slight advantage over the other. So clearly sitting in, you get to see the consultation skills, you actually physically see the patient, you get to immediately rectify any error made, and you get to question them and understand their clinical decision making. Whereas by the time you got to end of session review of notes, you're really only getting to review their clinical decision. Obviously, when I present this, for many people, they go, well, that's all well and good, but we're not paid for doing that kind of work. We don't receive that amount of money. So one of my other positions that I've had, I was on the Medicare task force looking at that. And I did put up a proposal to get a supervisor fee for service for Medicare payment for when the supervisor goes into the registrar's room. Unfortunately, that didn't get up. My other proposal, which was to remove the restriction on aftercare for GPs, did. So the reason why myself and 2 other GPs put that up, and the reason why that restriction on aftercare payment was removed. So that's probably my bigger claim to fame. But getting back to this, obviously, for many people, they're going to say, well, look, I can't do this. I'm just not paid for it. The argument back against it is that maybe in the long run, it is a bit better. I certainly feel that I get asked fewer questions. I sleep a bit more comfortably in bed at night, knowing that I have reviewed all my registrar's consultations. So I've been a supervisor for 30 years. In the last 3 years, I've routinely, for the first 2 weeks, reviewed every consultation. It was a bit hard to get past my colleagues, but once we've got in there and we're all committed in together and we shared the load, it's been worthwhile. Certainly, I'd have to say the other side of why it's been worthwhile is that the moment you mention it to your registrars, they can't thank you enough. They're just so grateful. As I mentioned earlier in the earlier slide, registrars are nowhere near as prepared as they used to be for the work of being a GP. For many of them, it's the very, very first time they've been making decisions for their patients. And when the door closes on them, they feel very confronted by it. The main point of this slide, of course, is that it's quite stunning to realize that it's the 18 to 30-year-olds, it's the younger doctors who are most emotionally exhausted and stressed, most cynical, and have the lowest professional efficacy. This is from a mental health survey run by Beyond Blue back in October 2013. Have no reason to suspect that it's any different. And so adopting this closer supervision model is well received. The other thing I want to point out in this slide is that in about a year's time, I'm going to be much less emotionally exhausted than I am. I can't wait to feel 11 from 21 and be way less cynical. So I'm really looking forward to that. So it doesn't appear to make any difference to my professional efficacy when I shift to that next decade. That's obviously, for many people, that's fairly confronting about how I'm suggesting doing that.
You make a really nice point around you'd never actually build a system like this, but it's evolved. And in a sense, what we're trying to do is retrofit it, or thinking about retrofitting it to enhance patient safety. There's probably a lack of evidence. I mean, you presented a very small bit of evidence around the patient safety issues, but we just don't have the evidence. And so the evidence lack may suggest that, well, it's kind of working all right.
Yeah.
But that's very different to a lack of evidence, which probably would suggest that it's not. I think that's pretty compelling. You're talking about the experience of a registrar, the support that they feel, as opposed to feeling like they're just shunted into a room and there's somebody really helpful down the corridor, but it's still that sense, this is another time I've got to interrupt them in the day.
I'm just wondering about just the practicalities of how you supervise the registrar when you're trying to balance your own appointments or demands for your appointments and encouraging them to get more appointments so that they get a broader range of experience. But for those first 2 weeks, how do you actually do that practically?
Practically, it's hard. I remember the first time I came across this, there was actually a GP, I think it was in Parkes, who said she took home the notes at the end of the day and read through every single note at the end of the day. So she was doing level 2 supervision. In February, when registrars start, I'll be working a couple of extra days where I'm just going to be going in, not consulting, and I'll just be sitting and observing or waiting for their call at the end of the consultation. I'll do one session that way. It is a increased amount of work for which, as I acknowledge, you're not paid. So it is quite a challenging thing to do. I'm also aware of there's another famous doctor, Peter Stevens, supervisor in Hayfield, and he does this for all of his doctors, not GPT-1s, but everyone, GPT-2s, 3s. He parallel consults them all until he's happy that they're ready to go. So work done by Simon, another project called Recent, where they looked at how often a registrar calls. Even if you're doing the other model, registrar calls on average 2 times a session at about 8 or 12 weeks. Anyway, even if you're doing the other model, you've got to, at the start of GP training, you've got to be crossing off time because you can guarantee you're going to get those number of calls.
Is there any way to fund this? I mean, you've just portrayed the cartoon of the dollars in one hand, and practically, how do supervisors engage with this when your Medicare proposal fell down?
It is difficult because we haven't got the evidence and we can't sell it. My experience asking around supervisors, about somewhere between 5 and 10% operate on this model currently, and 90, 95% don't. And those that do will take it on as something that they elect to do. Oh, having said that, I'm aware in Queensland, what used to be called tropical medical training up at far north Queensland, they were funding the first 2 weeks to be supernumerary. So there's obviously plenty of political moves afoot to try to get this. I think the colleges would like to see this sort of higher level of supervision at the start. If you think when we used to have PGPP, that was very, very well funded. Supervisors were happy to do that when you had interns in your practice and every patient was reviewed. But currently we need the political winds to be going our way. Or alternatively, all the owners look at each other in the eye and say, well, we're just going to do it.
Do you find that when you're sitting in that first couple of weeks that the patients will often defer their questions to you? Because I know when through our RTO we do the direct observation visits, and whenever I sit in, if it happens to be my patient, they try and talk to me instead of the registrar.
Absolutely. And I think, the experience of when you're a visitor going into another practice is quite different from being a supervisor. Yeah, they come in and they want to talk to you. And also what happens when you sit in, there's a disadvantage of sitting in when you're a supervisor is sometimes the registrar's got you there. They get about 20 seconds into the consultation and start asking you for help. So I like to do the sitting in because by sitting in, I get to see their consultation skills. But after that, I'm actually quite happy for them to run it and me come in at the end. I prefer that model, but I do think some direct observation, that's the only way you're going to observe their consultation skills. And once I'm happy that they've got my bit on what I want them to do in the consultation, I happily let them shift on to the other model.
But it is extraordinary to think, isn't it, that if we built the system tomorrow and this is the way it was, presumably funded, which would make it would just make sense to do it that way. But
it's come out historically because previously you had a medical degree, you were therefore you don't need supervision. If you've got general registration, APRA doesn't require you to have supervision. So we've seen a medical degree, you're okay to be a GP, so therefore you don't need supervision.
Yeah. And
we also set it up.
The time in the hospital, as you say,
getting all those skills,
the extraordinary range of skills that you could apply in general practice, which we're not giving to our RMOs now.
So I'm going to ask you perhaps to reflect upon when you are not reviewing all of your consultations, how you ensure your registrar patients are still safe. When your registrar is just calling you whenever they want to, how do you make sure that they're safe in that environment? What do you do? When I speak to supervisors, generally they say to me, well, eventually I'll find out if they're no good because I'll end up seeing a patient after them. One of my patients, they've registrars sent it, they come back and see me, I look at their notes, I'm going, oh my goodness, that's a problem there. They'll make a complaint or the receptionist will tell me that the patients are coming out and complaining about that person. So that's what I call fortuitous review, fortuitous discovery, rather than a planned process to go. And my concern with that model is by the time you find out, it's often a fair bit down the track. And what happens if we've already heard, you're a very busy doctor and you've got, like most of us, you're ending up seeing just your own patients back again and again and again. And that drug-seeking patient who says, well, I can go and see the registrar, you're never going to see them. And you're never going to know the terrible errors that they're making because it's not going to happen to you. Your practice is set up in such a way that you're not really going to see what your registrar is up to. So you need a system. And much of our work also was started by a great article even before Simon and I did random case analysis, asking this question, are they safe in there, which is the topic of this title. And it suggested that we believe that patient safety depends upon detection of unconscious incompetence by regular use of practical techniques that look beyond the door of the closed consulting room. They talked about random chart review. Simon and I turned it into random case analysis. So let's talk about random case analysis. So what is it? It's all in the name. It's random, not technically random as in generated in a randomized controlled trial, but in fact, just that it's random in that it's not selected by the registrar. And that's really at the core of it. I mean, the registrar is selecting you cases that they want to discuss. You're never going to see their unknown unknowns, or unless there happens to be an unknown unknown buried in the one that they present to you. So we want them to be random. We also want them to be ideally recent because we want to uncover their clinical reasoning. What were they thinking? What was their understanding? Why did they not order the D-dimer immediately? We want to know what their thinking was, and it's much easier to unpack your thinking from something recently. It's said that you can go back up to 2 weeks, but really I'd probably go the days before. It's then a case. So it's not, we don't look at the case, but we actually ask the registrar about what they remember about the consultation, what else happened, what else they recall. And then there's analysis, which is a discussion, and we consider the decisions are made. And that's where the name comes from. So what's the process we do? For any teaching, we like to think of there's a set. So you're setting something up. Then when we open the notes, so the set process is about explaining why we're doing random case analysis, what's the point of it, why are we looking at it. So explaining it to your registrar. Otherwise, they're going to feel like you're suddenly looking for faults, but you're explaining, look, this is a process which is known from the evidence that often registrars won't call for things they don't know. So that we're doing this random case analysis as a well-accepted technique to help us uncover things and to help you with things you may not know that you don't know. When we open a record, we clarify things. What does that abbreviation mean? And what else were you thinking? What else happened? Had you seen this person before? Explain a bit more. Then the exploring is further. We ask questions, which I'll go through in a minute. So why, what, and what if questions. And then we provide some feedback and assessment at the end of each one. So let's look at the exploring side of the random case analysis model that Simon and I developed. We proposed there were two ways of exploring the consultation. One was to reference it to the domains of general practice, and you could use the acronym domains just as easily. The RACGP domains, we could look what things about communication skills are in this record in front of me, and in this case, which we're discussing, what population health issues come up, what professional and ethical issues came up. So those 5 domains, which hopefully you're quite familiar with. Here's some example of those sorts of questions. And I've called them the what and the why questions because they really relate to the domains of general practice. What was the patient's agenda? What do you think they were wanting? What differential diagnosis were we considering? So the first one, what was the patient's agenda, might be the domain 1, communication skills. The next 3 questions there would probably relate to domain 2, clinical skills and knowledge. What are the appropriate red book screening tests for this patient? That's population health. That's domain 3. What item did you bill and why? That's actually a very useful question for us supervisors. And that's clearly in domain 5, organisational and legal. So you can actually, I think, go and look at the guide which we produced with GPSA, and you'll see a whole range of questions across the domains that you can ask. You obviously don't ask all of them, and you don't ask one from every domain, but you judiciously select from them according to what would appear to be most relevant. Then there's further exploration, which we're going to call the what if question. So if you think about any notes that you look at, there are 4 things which could be different. So first of all, the problem could be different. It could be reflux rather than ischemic heart disease. The person could be different. They could be older, they could be younger, they could be Aboriginal or Torres Strait Islander. Gender could be different. There's a lot of differences in people, as we know. The system could be different. You could be, as I am, as a rural GP, or you could be in a city GP. Your availability of services may be quite different, and that would affect your decision. So you can ask about that. And then, of course, you as a doctor could be different. You may have different skills, different experiences that influence or what happens. So they're what we call the so-called what if questions. So here's the example. What if he was an Aboriginal or Torres Strait Islander? What if he was a different person? What if he had not lost consciousness? What if, in fact, the problem was different? What if you didn't have access to troponin testing? What if the system was different? What if you were licensed to prescribe methadone? How do you think that might make it different? And this is where you can extend even those dull notes to be exploring further. Just going back again, there's the what and why questions relating to the domains of general practice, and then the what if questions. So there's a lot of questions you can ask about notes.
Yeah, I wonder, Jared, some people say to me, the why is very interrogative. It's very analytical and potentially a bit critical. Why did you do that? Why did you do that? And clearly we use the what, the why, what ifs as the theme, but it's also a bit the how come. So how come you were led to that? And that's that real interrogation of reasoning that I think it just leads to.
And it was a concern. I know when we first started teaching, we'd break supervisors into groups and go around the room, and they had these artificial notes to look at, and they'd start questioning their role-playing registrar in front of them. We'd go around the room, and it did feel like the Spanish Inquisition. It did feel like people were being questioned. Where were you on the night of such and such, and why did you do this? It obviously needs to be done a bit more sensitively, as you were suggesting. How come? Yeah, that's probably a more gentle way to come to that. And what were you thinking at this time? Gentler, probably less of the whys. I'd also have to say that we've got 6, 12, maybe 18 months, 2 years with our registrars, and we want to establish a relationship with them. So generally, I'm looking at their notes and praising up all the wonderful things that they've done early in the term and reminding them of how tough it is, general practice is. And I don't really expect them to be an expert from day one. And I'm spending a lot more time building up the relationships rather than questioning them and criticizing them on what they've done. And I don't necessarily pick up everything which I see in those notes. It's judicious. It's the same interpersonal skills you use with your patients. You judge how far you can go, what you can say, and you're using those same interpersonal skills which we bring to our consultations, we can also bring to this moment. The other reason to enable fewer questions is I can actually get to review more records. So if I want to check on safety, I actually need to review a lot of records. So if I spend a lot of time asking what and why and what if questions for one record, I never get to see another note. Those extra questions are a way of extending what I have. But if I want to actually see a greater depth of what they've been doing and what their understanding is, then I actually need to not ask so many questions so I can keep going. Having done this, you need to be thinking about feedback and maybe assessment. I'll talk about those two things. Registrars complain that they don't receive much feedback, and supervisors say, I'm giving them feedback all the time. So perhaps we're not making it explicit enough. There's an opportunity for you to give feedback both after each case that you've reviewed, plus also at the end after reviewing and summing up what's been learned and what's different. And the feedback conversations, you can actually even ask for their own assessment. What do they think of their records at this time? If you can get their own assessment before you give yours, that's always a better way of going. That's, I suppose, feedback. And we talk about feedback conversations more than me giving feedback to you, but having feedback conversations. What's the difference between feedback and assessment? Assessment is when you're adding in, well, is it at the standard? So feedback with a standard. So is this registrar functioning at this level that you would expect at this stage? Are they functioning at the level which you would think that they would be to be able to pass the exam, to be an independent practitioner? So assessment is when you add in a comparison of the work which you've seen to that. And that's, in this context, it's called formative assessment. So it's assessment for learning. Look, we're giving you this feedback. We're having this feedback conversation. This is the bit, looking at that record, that all looks to be up to standard other than this bit. And I think if you were to do this, that would bring it up to the standard. That's formative assessment. So called assessment for learning, rather than summative assessment, which is at the end of training, which is assessment of learning. So you definitely say what specific improvements need to be made. So that's an important thing to add in at the end of random case analysis. So in terms of, if you want to read further about random case analysis, there's obviously the initial work which Simon and I did, and which I think also informed very heavily the random case analysis and general practice guide. My take-home messages, again, if I haven't spelt them out clearly already, is that you are responsible for your registrar safety. Consider whether you can employ some mechanisms, even for a limited time, to review all consultations until you're sure that they're safe. That'll have an advantage in terms of ensuring patient safety. It'll be well received. Your reputation as a practice will go up very highly. My other take-home message is that once you stop reviewing all consultations, or if you're not planning to do that from the start, you need a systematic method to ensure that you're picking up where the registrar isn't asking you for help, and also picking up where they aren't asking for help, even though they know that they should be. That's also even a greater worry sometimes. And the method par excellence for achieving that is random case analysis.
I was just wondering, for people that have had experience, because I haven't had a registrar yet. My first registrar comes in February.
How exciting.
When I've done another talk, they had a list of clinical situations which they listed as red flags that they suggested you would give that to the registrar, and anything on that list needs to be double checked with somebody before they finish up. And I just wondered, is that practical to apply?
So the idea then, if you're going to move beyond reviewing all consultations at some stage, you want to at least have a conversation about, are there areas that they recognise that they want to ask you help for? So there are lists created. There was an original list created by the RACGP some time ago, and I was actually involved in publishing another list, which might be the one you're referring to, called the Call for Help list, which was a list developed where I asked a whole bunch of supervisors and registrars, what are the common things which I think registrars should be calling for help with and haven't been calling for help with? And so this was a list to create. Now, I'm not convinced that this is a practical method that someone's going to tick off because I think there's about 70 things on the list, and I don't think you're going to be able to tick off each one with your registrar. But I think it's a useful conversation starter with your registrar to say, look, here's the sort of things I'm expecting you to call me about that. Because there's things on there that people wouldn't think that they'd be needing to be called. First time you do a work cover certificate, first time you prescribe S8 medication. So it then sets the registrar up that there's an expectation that they will call you. Because it said the most important thing for safety in that context is that you're approachable and available. And this list says, I'm expecting you to call me for these things. You could go further and actually you tick off each thing as they're done. You're safe to manage breast lumps. Yes, tick, it's done. But even then, that list is not full and comprehensive. There's still other things which will sit outside it. So even though I created that list as a supervisor, I have a conversation and I sit down and learn about what are my registrar's current strengths and weaknesses. Where do they think they'll need some help? And I'll find out about their previous experience and use that as a conversation starter. But I don't actually use that personally throughout the term. I prefer to invest more early in the term and sit and observe a large number of consultations at the start. I can see there's questions. You feel like I need to look in depth at my registrar and have just heard that in Queensland it's okay to review video consultations. Is that right? How do I find out what protocol to follow? I know in Victoria and in New South Wales, I mean, it's definitely okay to look at video consultations in all circumstances. The tricky part is that when you review a video of a consultation becomes part of the health record. And so you then have to retain that health record in Victoria and New South Wales for 7 years, the usual requirements, which for most of us, when that came in, we all said, well, I don't have the storage to be maintaining that record or a safe place to retain it. So review of video consultations is an incredibly powerful tool. And as you say, once they've got the video there, they're not so influenced by your presence in the room. Am I legally allowed to go and look at someone else's notes? The patient hasn't consented to me looking at those notes. And yes, you can. The same legislation, which is different in every state, allows you access to notes. You're allowed to look at notes in that circumstance where it's for purposes of quality improvement and safety, where it's not feasible to gain patient permission. That's allowed. It's the same rules that enable when your practice gets accredited, when the accreditor comes around and opens up the records. It's the same allowance in that sense. So you're legally allowed to do it.
So that's an interesting comment, Jared, about Zoom. There's
so
no
I think,
record to store.
Well, if you're watching via Zoom, you're actually watching it live. So that's the same as you sitting in the room, technically. So you haven't recorded it. So therefore, it's the same. Whereas, of course, there's the capacity with Zoom to record as well. So if you did a recording via Zoom, you would have to, in the states that I know of, Victoria and New South Wales, you are required to maintain that record.
I think, if anything, this would highlight to me and just the notion of this explicit sense of, is the registrar safe? What am I doing to ensure that? What constitutes an adequate safety assessment of a registrar early in the term and in an ongoing way? And clearly RCA contributes to that. But I think I have seen and had experience of supervisor registrar interactions where maybe that's just not quite as explicit. It's in the background, clearly, it's an important thing, but if we actually stop and say, do I know my registrar is safe? If somebody was to come up to me and say, are they safe? You probably have an idea, but how can I give, what's the evidence here? And I guess that's what you're getting at when you talk about RCA and these other methods we've talked to.
Yeah. When we did our research, that one would produce those figures, we asked supervisors, are you confident that you can assess whether your registrar is safe? And supervisors' confidence before they use RCA and after they used RCA was a significant jump. They were confident that they knew that their registrars were safe or not, because they'd seen enough of their work to be able to do it.
Jared and I are very passionate about this particular education method. It's by no means our invention. It's been running for a long time in the UK, but it was a great pleasure to be able to introduce it to Australian general practice training. And it's really heartening to see how much it's been embraced. So we're very pleased to be talking to it. Jared, thank you very much.
Thank you. Thanks all.
Lovely to work with you. And
again,
thanks so much.
Bye now.
Thanks for watching. We'd love your feedback. Please comment or subscribe to our YouTube channel for updates on new videos. If you'd like to ask a question or suggest a topic, you can contact us via our website at gpsa.org.au. GP Supervisors Australia is supported by funding from the Australian Government under the Australian General Practice Training Program.